Hello, I'm Dr. James R. Gavin, Clinical Professor of Medicine at Emory University School of Medicine. Welcome to the Farxiga presentation, Utilization of Farxiga as Add-on Therapy to Insulin. You just reviewed information related to the use of Farxiga as initial combination therapy with metformin XR in patients with type 2 diabetes who were treatment naive. In this module, we will focus on the use of Farxiga as add-on therapy to insulin in adult patients with type 2 diabetes. We'll also review data related to the effects of Farxiga on A1C, weight, and blood pressure. Please note that Farxiga is not indicated for weight loss or the treatment of hypertension. Let's begin with a quick overview of the full Farxiga clinical development program. 24 Phase 2B and Phase 3 studies were included in the clinical development program. These studies included more than 11,000 adult patients with type 2 diabetes, some of whom were drug naive, others were already receiving oral therapies, and some were on insulin-based regimens. More than 6,000 patients received dapagliflozin in these studies, which included both placebo-controlled and active comparator designs. The studies included in the Farxiga prescribing information ranged from 24 to 52 weeks in duration. As stated, we will focus on utilization of Farxiga as add-on therapy to insulin in this module. This study included 808 adult patients with type 2 diabetes and inadequate glycemic control who were on a mean insulin dose of at least 30 units per day for at least 8 weeks prior to enrollment and up to 2 oral anti-diabetic drugs. In this study, inadequate glycemic control was defined as an A1C of 7.5 to 10.5%. Patients who met eligibility criteria were randomized to one of 4 treatment arms: placebo, dapagliflozin 2.5 milligrams, Farxiga 5 milligrams, or Farxiga 10 milligrams. Treatments were administered once daily as add-on to unchanged background insulin therapy, with or without concomitant oral anti-diabetic drugs, for 24 weeks. Basal insulin treatment and multiple daily insulin injection regimens were allowed. Please note that dapagliflozin 2.5 milligrams is not an FDA-approved dose. Therefore, the results of this arm are not presented in this presentation. The primary efficacy endpoint was the change in A1C from baseline at week 24. Select secondary efficacy endpoints included the change in total body weight from baseline at week 24, the change in calculated mean daily insulin dose at week 24, and the proportion of patients with calculated mean daily insulin dose reductions of 10% or more from baseline at week 24. Patients with inadequate glycemic control during the treatment period did not receive oral rescue therapy, but received up-titrated insulin therapy. Up or down titration of insulin was only permitted during the treatment phase for patients who failed to meet specific glycemic goals. Let's review the primary efficacy endpoint results for the study. Farxiga as add-on therapy to insulin provided a statistically significant reduction in A1C. At 24 weeks, Farxiga 10 milligrams reduced A1C by 0.9% in combination with insulin versus 0.3% in the placebo plus insulin group. Reduction in A1C was 0.8% from baseline with Farxiga 5 milligrams plus insulin. The effect of Farxiga on A1C levels was similar for patients treated with insulin alone and patients treated with insulin plus any additional oral anti-diabetic drugs. There was one episode of major hypoglycemia reported in each treatment group. Minor episodes of hypoglycemia were reported in 40.3%, 43.4%, and 34% of patients in the Farxiga 10 milligrams plus insulin, Farxiga 5 milligrams plus insulin, and placebo plus insulin groups, respectively. One of the secondary endpoints in this study addressed the change in total body weight from baseline. At week 24, the group treated with placebo plus insulin had no change in weight. Patients who were treated with Farxiga 5 milligrams or 10 milligrams had weight reductions of 2.2 and 3.7 pounds, respectively. Please note, Farxiga is not indicated for weight loss. Another secondary endpoint of this study was the reduction in mean daily insulin dose at week 24. Patients in the Farxiga 5 milligram and 10 milligram plus insulin arms experienced significantly greater reductions in mean daily dose of insulin from baseline than did patients treated with placebo plus insulin. By the end of the study, significantly more patients treated with Farxiga 10 milligrams plus insulin reduced their mean insulin dose by at least 10% compared with patients taking placebo plus insulin. In the studies we have reviewed today, which included Farxiga as initial combination therapy with metformin XR in treatment-naive patients, and Farxiga as add-on therapy to insulin, significant reductions in A1C from baseline to end of study were described. At this point, I'd like to summarize results of additional clinical studies. Starting from the left of this graphic, let's first review the A1C results of the monotherapy trial. Following a 2-week diet and exercise placebo lead-in period, patients with A1C of 7 to 10% were randomized to Farxiga 5 milligrams or Farxiga 10 milligrams once daily, or to placebo. At week 24, Farxiga 10 milligrams provided significant improvement in A1C compared with placebo. Moving to the right, the results of Farxiga as add-on therapy in patients receiving at least 1,500 milligrams of metformin per day are shown. Adult patients who had inadequate glycemic control on metformin participated in this 24-week placebo-controlled study. Patients were randomized to either Farxiga 5 milligrams or 10 milligrams or to placebo in addition to their current dose of metformin. Farxiga 5 milligrams and 10 milligrams as add-on therapy to metformin provided statistically significant improvements in A1C compared with metformin monotherapy. Next are the clinical data from a comparison of Farxiga to glipizide as add-on to metformin. Patients on a stable dose of metformin 1,500 milligrams per day were randomized to glipizide 5 milligrams or dapagliflozin 2.5 milligrams and up-titrated to 20 milligrams and 10 milligrams, respectively, as tolerated, to achieve optimal glycemic effect. As shown, Farxiga plus metformin led to the same mean reduction in A1C as glipizide plus metformin, demonstrating non-inferiority of Farxiga to glipizide as add-on therapy in patients uncontrolled on metformin alone. Farther to the right are the results of a study evaluating Farxiga in combination with glimepiride. As shown, A1C improvements were significantly greater for patients receiving Farxiga plus glimepiride than for patients treated with glimepiride alone. In another study of Farxiga as add-on therapy, Farxiga 10 milligrams or placebo was added to sitagliptin in adults with type 2 diabetes who were drug naive or who were treated at entry with metformin, sitagliptin, a DPP-4 inhibitor, or the combination of the two and had inadequate glycemic control. At the end of the 24-week study period, patients treated with Farxiga plus sitagliptin had significantly greater improvement in A1C than did patients treated with sitagliptin alone. The rightmost data shows the previously reviewed statistically significant reduction in A1C that was achieved when Farxiga was added to insulin. Change in body weight was included as a secondary endpoint in several of the studies, some of which we have already reviewed. As shown, treatment with Farxiga 5 milligrams or 10 milligrams in combination with other treatments for type 2 diabetes provided statistically significant weight reductions at week 24 or at week 52 compared with placebo plus comparator treatment arms. Again, please note that Farxiga is not indicated for weight loss. The effect on blood pressure was another endpoint that was assessed in several of the Farxiga clinical trials. As shown, treatment with Farxiga 5 milligrams or 10 milligrams in combination with other type 2 diabetes agents provided statistically significant placebo or comparator-adjusted systolic blood pressure reductions at week 24 or week 52. Please note, Farxiga is not indicated for the treatment of hypertension. Before we close, I would like to review the indication, limitation of use, and contraindications for Farxiga. Farxiga is indicated as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes. It is not recommended for patients with type 1 diabetes or for the treatment of diabetic ketoacidosis. Farxiga is contraindicated in patients with a history of a serious hypersensitivity reaction to Farxiga. It is also contraindicated in patients with severe renal impairment, end-stage renal disease, or in patients on dialysis. Please note that the full prescribing information, including the medication guide, is available from your AstraZeneca representative at this presentation and also by visiting the Farxiga website at www.farxiga.com. Thank you for joining us for this Farxiga presentation. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have any comments that could improve the delivery of our promotional educational programs, please contact AstraZeneca at 1-800-236-9933. Thank you for your participation. This concludes today's program.